Hello, and welcome to Quick Hits, where we explore the intersection of healthcare and technology. Today we have a special guest, Dr. Nigam Shah. Dr. Shah is Stanford Healthcare's chief data scientist and a professor of medicine at Stanford School of Medicine, where he specializes in biomedical informatics. He's a physician scientist who's been turning big health data, like electronic health records and even wearable data, into practical insights that help doctors make better decisions. Many patients don't fit neatly into clinical trial results, so Dr. Shah pioneered ways to use real world evidence from everyday patient care to fill those gaps. In short, he's bridging the gap between cutting edge research and real world clinical practice. Dr. Shah is also a leading voice in ensuring AI in healthcare is done right. He emphasizes making AI tools useful, reliable, and fair, keeping patient well being front and center. With hundreds of research papers and even multiple startups under his belt, his credibility in the field is second to none. In this episode, we'll tap into his expertise on responsible AI and how data can truly improve patient care.
And welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host, Tyler Smith. Tyler, how are you this week?
Thrilled to be here, Ken.
Excellent. Yeah, we've got a great guest here. We are talking to a man who wears many hats. He's the chief data scientist at Stanford Healthcare and professor of medicine at Stanford School of Medicine, Dr. Nigam Shah. Welcome to the show.
Great to be here.
Yeah, we're so glad to have you. Like I said, you wear so many hats. Maybe if you could give us a little insight, tell us a little bit about your journey into biomedical informatics and kind of what drew you into this data science slash healthcare world.
It's like all good things, a series of fortunate events is what brought me here. I did my medical training in India. I was going to be an orthopedic surgeon. My father's a surgeon, and we happened to have a family friend who did his PhD in the U.S. in the early 70s. So he convinced me to apply for a research study and say, take the GREs, apply for grad school, and if you don't like it, you can come back and still be a carpenter. I mean, what do you got to lose?
Mm.
And he had a point, and so I applied and got into a bunch of places. I was fortunate to be admitted to Baylor College of Medicine, which I declined because it was just a college, and I'd already been to medical college. I went to Baylor Medical College. And so, long story short, ended up at Pennsylvania State University, Penn State. And that was the year, August 2000 is when I joined. And that fall is when the Human Genome Project hit the mainstream press. And
Okay.
front page of the New York Times, the Times Magazine, Nature, Cell, Science, everybody's talking about the Human Genome Project and how computers and this thing of using DNA sequences and the information therein is going to change medicine. And I just got hooked, and I lobbied my graduate program. I was in molecular medicine, and I said, guys, this new thing, I'm super interested. I didn't know any programming or anything at that point. And but I had an MD, and so they said, like, fine, we'll take a risk on you, and they let me be their first student to pursue this application of informatics or the use of information for medical purposes. That's how I started down the path. And then turns out Penn State's med school is 80 miles away from the main campus in Hershey. So either I do a long commute or I do my thesis work with something else. So I ended up doing my work in molecular biology, building a reasoning engine for yeast. And then when I finished, my committee basically said, doctors who do AI all go to Stanford, so you should go there. And literally, somebody flew me out on their frequent flyer miles in January of 2005. Jeff Schrager actually is the guy who did that. And I met my current boss. We just wandered over, knocked on his door, and he said, call me when you graduate. And I called him in August. In September 05, I joined Stanford as a postdoc, and I never left.
Wow.
Well, it's great timing on some of that, but clearly you had a desire and a passion. So that's great that you kind of wanted to be the first to enter that field there at Penn State. So you're at Stanford, and clearly you're leading a lot of efforts across academic and clinical environments. We've heard so many different perspectives, but how do you keep your work separate, or how do you balance your work as a chief data scientist and along with your research and teaching responsibilities?
Well, I often joke it's like one infinite loop. There's no balance. It's like this movie strip, right? I mean, it's just one thing. In some, I mean, it's a 50-50 split on paper, which is great because it's half. There's no counting days, anything like that. Um, and I research what I believe from first principles is what needs to be done, and 70-80% of the time it turns out that that ends up being the right thing to know before you deploy something. And then what I learned during the research and during the deployment work is what I get to teach in my classes. So it kind of balances out. It feels like a lot, but in practice, it's not as crazy as it sounds.
Sounds like it's a pretty healthy feedback loop across the different environments. Um, and it's really interesting because Dr. Shah, when we first met, crazy to think that 2005 was 20 years ago. First of all, but but we first met, I think, 2017 or 2018 when I was doing my MBA at Stanford, and I remember reaching out to you because you were essentially, if I'm correct at this time, mining insights from the EHR,
Mhm.
which was perceived as novel. And part of me wants to ask you, like, why was that perceived as novel? Like, it should have been like very obvious, but it wasn't at the time. And maybe if you could give a little bit more perspective on why it wouldn't be perceived
Mhm.
as novel, or if just no one felt like looking.
Yeah, no, it's a great question, and if we look in the literature as to when was the first time a physician or doctor tried to mine the data of similar patients in electronic form, turns out that was in 1972.
Wow.
Oh wow.
before we were born.
Yeah. Yeah. Yeah.
uh, and it never really took off for several reasons. I mean, the data were not electronic to begin with, so people had to sort of hand code paper into a computer. Computers weren't that great. There wasn't any strong incentive. And then several things happened over the years, but I think the landmark event was in 2008 and 10, where two things happened. The High Tech Act passed, and along with the ARA funds, the Rescue and Recovery Act, there was a massive incentive to adopt EHRs for health systems. And when people, so the adoption happened because, doctors and health systems were getting paid to use an EHR, so they started using an EHR.
Right.
But once you have enough data in electronic form, so let's say 2008, everybody starts adopting. By 2012, 15, most people have like 5 years of good data.
Mm.
And so now when you have 5 years of good data, and then by that time, computers had gotten really good and the statistics had advanced enough, and open source libraries for causal inference and all that had matured, a part of the Odyssey project and so on. And so then 2015 onwards, like, or 2017 when we met, is like it's in the air, like, oh, we have data on millions of patients, we have a powerful
Right.
computer, we have all of the statistics methods, and for the first time, we're trying to reduce cost of healthcare. So there's an incentive.
Right.
Right.
And so that's why everybody started talking about it right around that time.
Got it. So essentially, there was, even if you had the idea earlier, which someone obviously in the 70s had, there was just not enough data. And once meaningful use really got underway, took about, what, 5 years, it sounds like. And then there was enough data. So then there was something to look for, because otherwise, maybe there were others that had tried um, just to approach an empty lake, essentially.
Mhm.
Which, is that lake still empty at Stanford, or did they put the water back in there?
I know the lake lag is still empty. But I think you
Okay.
bring up a very interesting point. So the physician who did it first was Dr. Alvin Feinstein at Yale. And
Okay.
then there were other efforts. In fact, to sort of connect some dots, the department chair of medicine when we met was Dr. Bob Harrington. Bob Harrington, in his training days, was at Duke University, and Duke, DCRI to be specific, Duke Center for Clinical Research Information Center or something like that. They were doing Duke Cardiology Data Bank in the 80s. Uh, at that time, overseen by Dr. Rob Califf, who is or
Oh
was a
yeah.
former FDA commissioner.
Yep.
And so Bob Harrington and Dr. Califf tried to do this in cardiology in the 80s. In the
Hmm.
late 80s, early 90s, there were faculty on Stanford campus that did rheumatology, a project called Artemis. And so all of those prior efforts sort of build the intellectual power base on which in 2015 and later people could execute, given that now there was enough data.
So we went from a time when there was one doctor getting people to hand code data back in the 70s, and then today I saw a recent estimate that said that healthcare systems produce about 50 petabytes of data each year. So you were
Mhm.
talking trillions of gigabytes if you bring all that together over the course of years. So we're getting to the point where obviously we've gotten to the point where our traditional methods of combing through that data and producing statistics, et cetera, is just we can't keep up. And so enter the rise of AI. So let's talk a little bit about just AI making that data clinically useful. From your perspective, what does it take to translate a model from the lab into something that clinicians can actually use and actually start to get data out that helps drive better decision making and better patient care?
Mhm. So, I mean, the model is usually the easy part. Uh, then you have to ask the question, what is the model doing? And in medicine, I would argue that there's only two things that models do for us. They help us make a decision of whether to treat and might guide a decision of how to treat. And when I say the word model, it could mean anything from a logistic regression all the way to a deep neural network. At the end of the day, they produce an output, usually a number, based on which we make a decision about what to do, whether to do something and what to do. Now, the whether to do can further be broken into, is it a diagnosis problem that is being solved, as in figuring out what the patient has, or figuring out what the patient will have in the future? So, for example, you might have heard of things like, sepsis classifiers that tell you that, oh, this patient has sepsis, but hey, doc, you don't know yet. Or they might be predictors that anticipate someone who's going to get readmitted or who's at risk of dying. And then you can take appropriate action in response. So, for those kinds of models, the ones that help us decide whether to treat, medical speak for that is risk stratification. What matters is what is the recipient's capacity to take action. Like you and I can sit down and make predictions all day long, but if say Tyler is the doctor and he has to follow up on the recommendations we make,
Hmm.
it it does matter whether he has the time.
True.
And so,
Right.
as a very concrete example, specialists can build a classifier for who has undiagnosed peripheral artery disease. And GI specialists can build a classifier for who should get a colonoscopy. And then cardiothoracic surgeons might build something and so on. Then everybody deploys that. And then the poor primary care doctor now has 10 classifiers making him recommendations that thou shall do XYZ things with your patient in the
Mm.
15 minutes that are already too short, right? And so, for those kinds of things, what matters is work capacity. Like, do we have the time and
Mm.
space to do the work? Do we have the workflows to do the work? Like the rituals and the dance of medicine that creates the time, but also the process by which action would be taken. So those two, I think, are the most important thing: work capacity and having the workflow or the process by which we act on the AI's output.
Wow, that's a completely new perspective. I don't know that we've heard that before. So who makes the final determination on the capacity of the care provider?
That's the hard part because there's no one person in charge.
Mm,
We have made medicine so complex. Uh, so the example I would give, like, imagine a table with 50 columns and 100 rows. Okay, those columns are our medical specialties: oncology, rheumatology, pediatrics, emergency medicine, radiology. You go on and on. Right? There's about 40, give or take. The rows are the sites of service or sites of business, a clinic where you can go and get your skin checked or your ear checked or what have you. Now, one of those rows could be a place like emergency department, emergency room, rather. Now, emergency room, the row is staffed by physicians who are emergency medicine doctors, so one column, emergency department. But they're also staffed by people working in internal medicine, people working in trauma surgery, people working in anesthesiology, people working in radiology. Like, in order to make the ER run properly, you need these multiple specialties.
Right.
So that's the point I'm trying to make here, is that when we think about building AI, we're thinking about the columns. But when we think about deploying AI, it's the rows that matter.
Mm.
interesting.
And the rows refer patients to each other. Primary care refers to specialists, and sometimes specialists would then treat a patient and then send them back to primary care. And so the decision making is fragmented across this 5,000 cells in this table.
Mm.
And that is the problem. There is no one person who decides, do we have work capacity? And what is our process or workflow for following up on a prediction?
Well, when you put it into a database image that you just did, it seems like it's solvable because you've distilled it into a table. So, and you put a technology layer over it. I'm sure you've already thought of that. So, what is what is the limiting factor on using AI, or not? It sounds like you don't even need AI in this regard. It's just an algorithm for allocation of resources.
Yep. So once we had this aha moment, we were like, let's not worry too much about the AI. Let's worry about work capacity. Let's
Mm-hmm.
worry about workflow. Let's worry about, is it ethical to do what the AI would expect us to do?
Mm.
Is it financially sustainable? And so we came up with a evaluation regime we call a firm assessment: fair, useful, reliable model assessment. And we've written it up in the New England Journal Catalyst. And then from a practical standpoint, it's basically an assessment that we do on campus for everything that's going to go through a potential deployment, and just ask ourselves these questions like, okay, this model, let's assume the model works. Let's assume the AI works.
Right.
Who's going to take action? Do they have the time? Do they have the workflow? Do they have the necessary support staff? How many actions can they take per day? How's it going to be paid for? If we do these things, like, what are they not doing, and what are the ripple effects of that? And it's a thought experiment with a little bit of simulation and some Excel calculations and stakeholder interviews to take the viewpoints of multiple involved parties. And then the end result is a short 3-4 page report that says, if we do this, these many people will be affected. This is what the stakeholders think is good. This is what they think is bad about the process. This is how much work capacity and labor it's going to take, and this is how much it costs. And then the executive leadership can make a decision based on that.
Excellent. Well, I thank you for walking us through that. It's awesome to just sit there and kind of understand the process and what goes behind it, and then remembering that there's real patience behind all of this. Are you able to? Are there any like recent examples, kind of where this approach and just this data science model has directly impacted patient care at Stanford Healthcare? Or do you have any like real world examples that we could kind of discuss?
Yeah, there's a couple. The one that we got a Hims Davis Award for was for using a model to anticipate mortality, and based on that, prioritize who do we have a conversation about advanced care planning with. And the models were the easy part. Like we built them back in 2017, 18, actually. The hard part was, all right, so model says this person is at risk, like, but what are we going to do about it, right? And so several physicians, notably, Dr. Winnie Tudberg at Stanford Healthcare, they did the hard work of coaching and training residents, fellows, physicians, respiratory care workers, spiritual therapists, med students on how do you have a conversation with somebody about advanced care planning? And then how do you document their goals of care? And that whole workforce training and culture change took like 3 4 years.
Yeah.
And then now I'm happy to report that we run this model daily. It flags a few people for follow up, and we're able to complete that follow up. And our rates of advanced care planning that used to be in the low single digits are now hovering over 15%. And about 6,700 patients have had advanced care planning and goals of care documentation because this model has been running continuously and the workflow is being executed in response. So that's just an example of, I mean, nothing flashy. The model is a gradient boosted model. There's no like deep neural networks there,
Right.
but it affects patient care in a positive way.
Yeah, it's interesting. Was listening to an interview with Dario from Anthropic recently, and one of the points I took away was a lot of the AI planning or anticipation is around all just downside scenarios. But you're this what you're relaying is like, okay, you all, before you gave this example, you all assume best case scenario with AI does its job. Okay, now once AI is doing what we intended it to do, how do we actually operationalize? So you're planning for the actual upside scenario, and then it's so multifaceted because you're planning for an upside scenario, and then the upside scenario in this case is actually sad because it's mortality. So it's really intriguing how it all kind of ties together. But I'd be remiss if we didn't talk about that dark side potential, and I know you talk about responsible AI, and so yeah, how do you define responsible AI outside of ensuring that AI is actually able to be leveraged, like which what you mentioned around resourcing, like okay, if it's actually predicting or the outputs are what we need, but how do we use them? But how much do you think about the potential downsides that I think get covered a lot. So I don't want to take it too far down that
Mhm.
route, but remiss if I didn't ask.
The downsides are, that's why we do the stakeholder interviews, because often what happens is that we only focus on downsides that the builder of the AI models imagine. But I think what matters is the both the pluses and the downsides that the impacted parties are concerned about. And often they're not the same as what the builder of the AI would have imagined.
Yeah.
And so, for example, in this mortality prediction, one of the assumptions was that, oh, we should be transparent and tell the patients the risk that was estimated and how. And when we interviewed patients, most of them said, like, no, tell my doctor and make sure they understand. Like, I don't want to know.
Right. Yeah, it's fascinating. We just spoke with Dr. Yah from Vanderbilt a lot around the ambient AI, and yeah, there was, I guess, some feedback when they've been talking about AI with their staff around, oh, this is what's going to replace our jobs. But in your example right there, it really shows that there is like it's not the information going. The patients don't want it directly. They want a provider involved. They want a human layer. Let's take a quick break. At Health Data Movers, we know that data migration isn't just about moving information from point A to point B. It's about making sure your clinical and operational data is accurate, accessible, and secure, so your teams can focus on delivering care, not chasing records. Whether you're consolidating systems, switching EHRs, or sunsetting legacy data platforms, our data migration experts help you move confidently through complex transitions. We bring proven tools, repeatable processes, and deep healthcare experience to make your migration seamless. If you're planning a system change or even thinking about one, let's talk. You can learn more at healthdatamovers.com. Now, back to the show. But curious, how you see the evolution of the provider in the next during this paradigm shift.
I think it's going to be case by case. I don't think a blanket statement would make any sense. So, for example, let's take another very simple AI that's been around for a very long time, actually. You've probably had a blood test where you get something called a CBC, a complete blood count or differential blood count, right?
Oh, yeah.
When I trained in medicine, we would look through a microscope on a slide and count the white blood cells with one of those clickers that, little silver gadget where you count how many people pass through. So we used to count the number of cells manually. Today, you put blood in a cell sorter, and it shines a laser, so there's a little bit of flow cytometry, and you get the CBC. No human verifies it or double checks it. So in that case, the AI has freed the human up. The pathologist that was looking through the microscope and counting can now focus the time on interpreting the result. No human in the loop. In fact, a human in the loop there would be detrimental. And so I think the way to think about this is that what is happening with the information? And do we want to spend the human labor on verifying the output that the AI produced? Or do we want to spend the human labor on interpreting the output the AI produced and taking action in its response? And I think it's more fruitful to be on the action side, the response side. But that's not what I see happening in the community. All the products being sold right now, pathology AI. Well, human has to verify the output. Radiology AI, human has to verify the output. Automated in-basket response, or human in the loop, they have to read the model's response. Like, you're actually increasing my work.
Right.
Now I have to double check everything. And so there's a little bit of a disconnect in the words people use. Like, human in the loop can mean two things. Human in the loop, where the human's kind of cleaning up after the AI and double checking it, or human in the loop as in humans taking handoff from the AI and doing something with the output that the AI cannot do.
Right.
And we confuse those two all the time.
So maybe then, and maybe this is already one of them. It sounds like it. So would love to hear even a little bit more about some of the misconceptions about implementing machine learning in health systems. And maybe human in the loop is the biggest one, but wondering if others come to mind as well.
Yeah, human in the loop is sort of the biggest one. The other one is a generalization of that, comes from one of our colleagues, Eric Brynjolfsson. The notion is what he calls the Turing Trap. So most people have heard of the Turing test.
Mm-hmm.
Yeah.
Where a computer pretends to be a human and gets away with it. A Turing Trap is that a human imagines using a computer for only those things that the human already knows how to do. And if you look around, pretty much every AI tool out there is an excellent example of the Turing Trap.
I like that phrase. I'd never heard that before, but that makes sense. And that's kind of what Dr. Yah was saying, right, Tyler? Basically, when people talk about, oh, AI is going to replace my job, whereas it's like, well, no, AI can do all of these other things that you're not able to get to enable you to do your job.
Yeah, so let me give a concrete example. When Tyler and I met in 2018 or timeframe, we had launched a project on our campus called the Green Button Project.
Oh yeah, that's right.
So Green Button, we completed the project in 2020 and spun out a company called Atropos Health. And both Green Button and Atropos, the idea there is let's do something that a human brain cannot do, but would want to do. So, for example, when you see a new case, you would want to make a decision that benefits from the care that has been delivered for millions of other similar patients in the past. But no human doctor can remember millions of patients. You can barely remember the 1,000 or 2,000 patients you've seen, um, or maybe 5,000 patients. Even recollecting all of them instantly is near impossible for a human being. But for a computer, no problem. And so we imagined a medical specialty, a bedside service, just like radiology, pathology, psychiatry, what have you. You have a question, you invoke a consultation with this informatics service, and within a day, you get a written report based on millions of other similar patients about what happened, what were the outcomes, and so on demand. Now, that is something that a human brain cannot do, but a computer can do quite easily. So it's outside the Turing trap. And now that it's being used on our campus, uh, there's about 383 physicians who routinely use these reports in making better decisions for their patients. About 1,000 reports get run every year just at Stanford.
Wow. So, looking ahead, then, what's one strategic move healthcare IT leaders can make today to prepare their organizations for the future of AI-enabled care delivery?
There's no one thing that would like
I
the
know I
magic.
keep on trying to put you in a corner.
Um, it's like, what's the one thing you can do
Yeah,
to ensure that
yeah.
your child grows up to be a good human being?
Mm.
And so, like, if we take that as a hypothetical, I mean, there you model good behavior yourself.
Right.
So, what can leadership do in order to make sure that AI is used correctly? Well, make sure that the leadership decisions are thoughtful in terms of what's the model doing? Do we have the work capacity? Do we have the work processes? And as our CEO likes to say, don't chase shiny objects. Like,
Right.
don't do AI just because it's cool, or don't do AI just to get a press release.
So, what are some misconceptions that you've seen as an educator? One, and then two, as like a data scientist. So, in those two different areas, have you either it's one example or two examples of just misconceptions about AI and about the future of healthcare that you've kind of helped correct for individuals?
I think the misconceptions differ based on the background of individuals.
Hmm.
Hmm.
So, like, engineers often come in with the mindset that let me build something that replaces the doctor.
Yeah.
Mm.
I was like, but why?
Right.
Yeah.
Like,
Yeah.
so, like, if a human spent 10 years training themselves, and you then go try to sell them something that, you just wasted 10 years, I'm going to make you obsolete. That's a difficult
Yeah.
sell, I would imagine.
Right.
I remember Vinod Khosla was pretty much touting that on campus when I was in business school. So.
Mhm.
Wow.
And then the other misconception on the physician side often is that they imagine doing technology only to be able to do stuff that they have already seen it do before.
Mm.
And so there's disconnect on both sides. Like, and Tyler just mentioned Vinod. Vinod actually funded the first idea. This patients like mine. And what I like to say is that he's directionally correct in terms of
Right.
what needs to be done. And as I think he says himself on occasion that the timing might be off.
Mm.
And so, you know, at some point, you do have to replace the physician, the human labor, if you want to make more progress and have capacity. Like the example we're talking about, me looking through the microscope to calculate the differential blood count, that's now automated. It happens in 5 minutes. It used to take 40 minutes to a human. Completely automated. And no pathologist complains that, oh, I'm missing looking through the microscope and counting,
Right.
right?
Yeah.
And were pathologies threatened at that time that is going to now replace them? Maybe, I don't know.
Hmm.
Uh, and so the thing to manage is the transition. Technology almost never leads to a reduction or complete job loss. If you look over and over again, and Tyler, I'm sure you've heard about this in business school classes. I mean, when automobiles came around, the belief was that people who drive other people around on horse carriages, their jobs will disappear.
Right.
But I mean, their jobs did disappear. If you only knew how to drive a horse, yeah, you're in trouble.
Yep.
But the number of humans who drive other humans around, that has gone up. We just call them drivers now.
Mm-hmm.
Same thing with ATMs and bank tellers. Like over and over again, when some part of the value chain gets automated or commoditized, the immediate next step gets decommoditized.
Right.
And more humans are needed to take care of it. And so the way to think about it is like not AI killing jobs, but how are we going to manage the transition of job reformulation?
Mm-hmm.
And sometimes it's hard because humans can't update themselves like software in 2 minutes.
Right. Right. Yeah. You can't just learn how to drive a car if you know how to drive a horse, but hopefully you have some basic ideas around the other parts of the service.
Mm-hmm.
And you do bring up a good point. I mean, it's literally every industry that's being impacted by this quote unquote threat of having their jobs replaced when really, it's just a transition, maybe faster than it was for the adoption of the automobile, but it's a transition into other avenues of care, kind of along the same pathway, but just doing a different thing, to simplify it. So it makes a lot of sense. But I can see the struggle in healthcare because I think too you have this you have the you always have to think about the patient. So like you said before, the patient wants they don't just want data. They're not going to do anything with that. I can't imagine what it would be like getting a notification of your mortality via email. That has to be delivered with care. And like you said, that took what 3 to 4 years of training to help have that conversation with people. So it's kind of seeing where things are going and then training to meet that need.
Yeah, the interesting part here is it's almost like we're in this phase where you went from horse to automobile to flying car. If you could give a little bit more of your perspective around the pace of change, because a lot of these models kind of cannibalize themselves, rightfully so. But is there a concern around how quickly the adoption is going to have to continue to go as breakthroughs continue to occur at an increasing pace?
For adoption by the healthcare system, I think we also have to think about sustainability from a business standpoint.
Right.
Like innovations can't get adopted and scale until we find a societal way to pay for them. And our current payment regimes in healthcare, and we've written about this, they only incentivize two things, which is to bill more and to pay
Mm-hmm.
less. So there's a definite issue here that all of this technical advances being done, they may not get adopted until we figure out different payment regimens that incentivize the use of such technologies for better care.
Mm.
Mm.
And that's actually an issue that's not talked about often. People just talk about, does this work? How would you evaluate it? We'll talk about human in the loop, and they'll talk about the implications on humans and ethics and so on. But none of that matters till we figure out how is this going to be sustained financially.
Right.
Yeah. Yeah.
Back to your point, EHR adoption didn't happen until the ARRA, which had a clear carrot and then a stick at a certain
Mm-hmm.
point.
Exactly. And so, it wasn't because we didn't have EHRs.
Right, right. Epic's what, 1979, and I know that was not the first.
Mm-hmm.
Okay, so is a massive government program going to be the solution?
I don't know. I mean, that's why folks like you have to figure this out. I mean, you have the MBA. I don't.
We're working on it. We're working on it. Excellent. Just want to thank you so much for being on the show, and we love to hear your experience and hear your thought process and just your perspective on the role of data science and healthcare. And we know that you'll continue doing amazing things, but I think one final question that we can ask is, can you take a moment to inspire future students, future healthcare providers? What can you say to someone who kind of has that interest in both technology and healthcare?
I think you have to get bilingual. One of the things that's holding back progress a lot right now is people understand like either medicine or technology. And in order for us to like truly make a difference, we need people who can speak both languages, so to speak. It takes a while, but there are enough opportunities these days that during MD, medical professionals, or during nursing or their pharmacy training, people can pick up the basics of technology. And as students go through their technology programs, if you happen to be at a university that has a med school, like walk over, talk to people, shadow a clinician, shadow a nurse. Do it for two weeks, and you'll learn way more than what you can by reading a news report.
Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.